where their hypertensive status typically is a lot higher, that they don't wanna exacerbate that with a lot of intravascular volume, but they still need it. And those hypertensive patients will still get nauseated even if their blood pressure drops from 180 to 140. They may still get nauseated because they still drop 30% below their baseline, right? Because they start to auto-regulate. And so sometimes you still have to treat nausea even if you look at their pressure and like, oh, it's not from their pressure, they're probably just sick from something else. No, if you drop them, hypertensive pregnant moms, enough below their baseline, you still gotta treat their nausea with either volume or a blood pressure. Okay, yeah, preload or co-load, typically on average, a liter for most patients, unless they're PIH, and then it might be less. Sometimes it's more than that. So you might have just a liter in when you do the block, and then you're still gonna run in another 500 cc's if they stay hypotensive. What's drug of choice for hypotension in labor and delivery? Phenylephrine, which when I started my career was contraindicated in labor and delivery. So now its sense has changed, and now it's the drug of choice. Can you use ephedrine? Yeah, absolutely. You can, but phenylephrine typically is a drug of choice because they're getting a sympathetic block, so you want to tighten their SVR. Phenylephrine works a lot better. But if I have somebody that's chronically hypotensive from an epidural placement, and they're just kind of borderline getting nauseated, feeling better, getting nauseated, feeling better, every time we go down and give them a little medication, I will commonly do 50 milligrams of ephedrine IM for those patients that are just constantly doing this, and that slow IM absorption will just smooth them right out. It takes 10, 15 minutes before you get the effect, so you may have to treat them with phenylephrine until your IM starts, but that's a good way to control those ones that are just, not chronically, but chronically after their epidural placement, kind of keep dipping down, and a little fluid bolus and phenylephrine, a little fluid bolus and phenylephrine. And eventually your phenylephrine may make them bradycardic where you go to ephedrine anymore. Okay, questions?
For our videos, we do an epidural video, spinal video, and then do we have to do a combo video?
Oh, we didn't even talk about CSE, did we? Is it on the rubric too?
There was 3 grading rubrics.
I only have epidural for the test.
Oh no, online there's 3 of them.
Yeah, I have all 3.
In the files,
Yeah.
in the files.
Yeah, there's 3.
We'll have to ask the boss about that, but
Is
let's
that
just
the
talk
grading
about
tool
CSE.
for exam 3?
There's,
The grading tool
there's
is
there's
or is
3
that just the
rubrics.
technique?
Before you
Just
guys
3
leave,
rubrics.
I'll go ask Dan. But just so you know, CSE technique, they make kits, and the kits they make usually will have both needles in it. They'll have a spinal needle and an epidural needle. Some epidural needles, I know it might show in naval, have a little hole at the bottom underneath the curvature where the spinal needle comes out and goes through. Some of them will just follow the curvature and come out. This one's not even gonna be long enough. And obviously they'll be long enough to get through the spinal needle. So typically with loss of resistance, if you've got your TUI needle, let's say, loss of resistance at that depth, how much deeper do you need to go to get into the subarachnoid space? Millimeters, right? It's so short. So you know once you come out, that tip comes out of that epidural needle, it's gonna go right through dura, and it's gonna go right into the spinal space, you'll get fluid. So people will place the epidural first, then they'll grab their spinal needle, and just through the epidural needle, they're gonna push the spinal needle. Usually you'll get a little bit of resistance as you're going through that curve, or you'll feel it as it comes out the end of the needle because you get a little resistance on the dura. And you'll usually feel that pop through the dura. Pull the stylet out, you'll see CSF. You're gonna dose your spinal with whatever you're gonna dose it with, and then you're gonna pull it out, and then you're gonna place your epidural catheter right behind it. You're gonna thread it through. Soft catheter, very unlikely it'll go through the dura hole. Potentially, theoretically it could, but very unlikely because it's a soft catheter, it'll just coil up in there. Do you still test dose?
Yes.
On your test dose, what are you testing for?
Heart rate.
Why? Yeah, but why intravascular? Why not the other one?
Because they're already
Because
doing
you
You
already
just
that.
block
gone
them,
into this
right?
one,
You just block them, yeah, you have no idea. So, exactly, so your test dose is checking for intravascular on your catheter thread. Okay.
I think I missed it. So you have the epidural needle and then the spinal needle threaded through the epidural, and then do you thread the catheter through that, or do you take
No,
the spinal needle?
Spinal needle comes out after you dose your subarachnoid block.
Okay.
Epidural needle goes in behind it. So this is one of the contraindications of why people don't like to do this, because depending what you inject in your spinal fluid, and let's say it's hypobaric or hyperbaric and it's sinking, but you want to maintain a level at T10, but you can't change their position yet because they've got a needle in their back, and you still got to thread this catheter in, which takes a minute or two. Then you got a test dose. Meanwhile, you're getting this medicine porosity setting up maybe in an area where you don't want it. So that's something that you have to take into consideration. What porosity should I use in my medication I'm going to do in my CSE that's going to give me time to finish my block, if that makes sense? Does that make sense? It's already taken effect.
Is this common?
CSEs? Yeah. So, everybody's dependent. Some people will use them all the time. I worked with a girl that did CSEs all the time. I typically only did CSEs on a couple of subset of patients. One was a mom that was primate, meaning first time pregnancy, and they wanted to try to go natural, and then all of a sudden 8 centimeters, they're like dying, basically, is what they think. Again, sorry, I don't mean to be rude in any way, but they're changing their mind, and yet even though I want a block to set up fast, but I don't want it to wear out, because primates still may have to push for 2 or 3 hours, and if you do just a straight spinal block, it most likely may wear off and they'll get all their filling back and they still haven't delivered. So I'll do a CSE. I'll throw it in, I get a quick block, they're like, I love you, I'm gonna name my girl Ted after you. And then I'll throw the catheter in case that block doesn't last long enough. Now I've got an epidural I can dose as it starts to wear off to keep her comfortable if she hasn't done.
Isn't it at that point you're too late for anything, or?
At 8 centimeters on a primate, most of the time, no. Because primates, they can go complete and still not deliver for 2 or 3 hours. So you have plenty of time. The other subset of patients I do CSEs on, a lot of times if you want a spinal block for a surgical procedure, but you want the epidural for post-op pain for a couple days after, I'll do the CSE, get the spinal block, throw the epidural in after for post-op pain. So there's a couple of subsets. Any other questions?
You don't worry about sharing of that's probably a dumb question, because it's barely past the tip of the epidural needle. But your spinal needle is going further, right? And pulling it out, you don't worry
Your
about.
spinal needle is already pulled out.
Don't worry about what, finish your
Metal.
question.
But isn't
Like
it
the
going
metal
further?
fragments
Yeah.
or whatever.
Yeah, do you worry about shearing
shearing?
of the spinal needle
It's
from the
just barely
epidural
there,
needle?
so it's not far enough.
I haven't heard of any case studies. Theoretically, that would be a concern, but I haven't heard of any case studies of that being an issue. So, but yeah, theoretically, I mean, that's for the same reason of pulling out a catheter, which would be more likely to shear than a piece of metal. But yeah, potentially. Chewy needles again though, or epidural needles are dull, right? It's not a sharp edge as opposed to, but a soft plastic catheter would catch that edge as opposed to a metal thing. But you could potentially get little shadings in there. Okay, anything else? All right, you guys come up and do your thing here. Lateral, again, it's the same thing. You're gonna feel your hip, mark your spot on what you think where you wanna go. And you just have to keep in mind that if you think if that spine curves down a little bit, when it does curve down, a lot of times it will rotate a little bit, right? If it's displaced a little bit. So don't just take into account that it's curved down and you think, okay, it's curved down, so I'm gonna go in here because it's probably rotated back towards center, and you might have to take more of an angle that's more like that to get to this pass space on lateral patients.
Would you not just put a roll to